A woke doctor gives biological DMARD to a patient with tuberculosis. Maybe your history included congenital hypothyroidism. A foolish doctor will give pure water to a patient who is volume depleted. Hey, big boy, there is a difference between dehydration and volume depletion. Dehydration is losing pure water. Okay, when I'm dehydrated, yeah, give me water. But if I'm volume depleted, I've lost water and salt. So you give me normal saline because it contains water and salt. A dorky doctor is the one who still thinks that pneumocystis is a cortisol. You haven't opened a textbook since man walked the moon. A pathetic doctor is the one who aggressively manages hypertension after an ischemic stroke. Have you ever heard of permissive hypertension? Okay, let's say you had a patient, very high hypertension who suffered from ischemic stroke. After the stroke, if you drop the hypertension back to normal very quickly, the patient can suffer from another ischemic stroke because of decreased cerebral perfusion. After a stroke, you allow for slightly higher blood pressure called permissive hypertension in order to keep the brain perfused. And a stupid doctor is the one who gives fresh frozen plasma as a volume expander. You can use normal saline doofus. There are tons of these. Keep these 12 facts.
All right. I thought that was fun. I think it's a good meal because it breaks down when you're going to get each one of them. Okay, let's talk about GI for a little bit. What time is it? And then we'll do our case study first. Dirty business, right? What happens? Digestion. So where do we absorb? So intestines, so small intestines, large, different things happening, right? Stomach, yeah, breakdown of stuff, right? Stomach. Is there an E on that? Oh, I promised I would try that. So, what kind of things are absorbed in the small intestine? Did you say it there? Oh, yeah. Oh. Me either. Okay, so think about it. Okay, so there's lots of stuff. You can see it on there. Nutrients, etc. What about the large intestine? What's mostly going on with water? Yeah, water balancing, electrolyte balancing happens in the large intestine. Water. What else? Excretion, not good one. Yes. Excretion where? Yeah. Okay. What else? Spitball it here. What can happen with these types of situations? Okay. Obstructions. What else?
Bleeds.
Bleeds. Okay. Yeah. Why?
Because of obstructions.
Huh?
I said because of obstructions.
Irritation.
Maybe. Irritation, bleeds. I'm going to put inflammation here. Ulcers, right? Ulcers. Trauma. Cancers. Right? Tumors, yeah. Tumors. Yeah. We're starting to see a higher prevalence of colorectal cancer in younger people. historically, screening starts at 50, like Cologuard. You can have Cologuard now, colonoscopies. Those are the kind of the gold standard for looking up in there and seeing what's going on. Now they're seeing a lot more people in their early 40s that are presenting with colon cancer or colorectal cancer. So they're in the process, I think, of changing those guidelines to include, I think they're saying at least by 45 start screening. And I think it should be a little lower. So cancers, please, okay. Let's look at absorption. So these can be where? They can be in the stomach, right? Can be in the colon, can be in the small intestine. So what is something you might notice relative to excretion with a patient that's bleeding?
Blood in the stool.
Blood in the stool, exactly. So you have blood in the stool. Yep, black tarry. What does that mean?
I'm in trouble.
Upper, higher up. It's had a lot longer to be able to get it all mixed in as that fecal matter moves on down, right? So you're gonna get this black tarry mist. You said the more red frank blood. Where would that be? Huh? Lower?
Or GI or
Real
colon
frank,
or
a lot of
something.
times it's gonna be, and if it's on the outside, it's gonna be hemorrhoids maybe, or something in the rectum, because you're right there, right? A little further up in the colon, when you think about your colon, you've got your ascending, your transverse, your descending, and then you have the rectum, right? So if you're up there in the, maybe the ascending or the descending colon, you might see some of this, but it's gonna be mixed in more, right? So, yeah, definitely pay attention to that, because you're gonna have patients that come in, they may be talking about stools. That's always something we're gonna talk about, when you're in ICU settings, hospital settings, even clinics. You're gonna ask them about bowel movement. You're gonna ask them about things like that, right? And most people, when you say, so what do your bowel movements look like? They're like, what's wrong with you? But lots of important details in there, right? So it depends on where it's at. You can have bleeding in the stomach. So you could be throwing up coffee ground stuff, right? Or if it's moving on, you're gonna get this more black tarry. So, okay, let's think of absorption. And let's think stomach. So let's look at stomach, and let's look at breakdown, right? Breakdown of stuff. Because this is a big area that we deal with. So what's going on in the stomach? Huh? Churning. Churn. What's one of the main components in your stomach? Acid. Yes, you've got hydrochloric acid, in fact, right? So your HCl, these are produced in your parietal cells. I don't know if I spelled parietal right. Parietal cells. Okay? You need this acid for a bunch of things. Okay? What are some of the reasons you need that acid in your stomach? Huh?
To break down food.
Yeah. Break down. What else?
Go back.
Yeah. Kills bacteria. So stomach acid can be a balancer for bacteria in the stomach, right? You have a lot of bacteria in your GI tract in general. Okay, so if you remember one of the, when we were talking about anticoagulants, one of the things to be careful of is you have patients, especially warfarin, because it's vitamin K dependent, right? One of the things to be careful of is you have patients on antibiotics, it actually kills the bacteria in the gut that produces vitamin K. And so that can impact bleeding, right? So that's one of the things to think about. That's bacteria in your gut. Bacteria that's in the stomach. I guess I didn't really put gut, did I? Okay. So, breakdown kills bacteria. So if you have too much acid in your stomach, what are you gonna feel like? You might have
Reflux.
heartburn, huh?
Nauseous?
You might feel nauseous, so you can see too much. Nausea, vomiting, yeah. That excessive acid in your stomach sitting there will trigger that part of your brain that says, hey, eat right? So think of overeating or being hungover, right? There's all kinds of things going on. But think of overeating or eat something funky, right? Goes into your stomach. Also triggers up here that nausea and that vomiting. So excretion, I'm gonna put, how do you spell diarrhea?
No.
Yeah. Ulcers, right? We talked about those already. And what I'm getting to here is how we fix this, because this is a lot of what we talk about. For GI is how we prevent, how we fix, right? We futz with everything. I'm sorry that I'm behind you guys, because it doesn't. The board should be up there, but. So stomach, let's see here, absorption, acid. What else can you guys think of? Anything else?
As far
No?
Hernias?
Okay, that could be something, like what type of hernia?
Strangulation in like the intestines?
Okay.
Go inwards on itself?
Okay, yeah, which would kind of lead to an obstruction.
Yeah.
Yeah, but that could be traumatic, that could be, and that's one of the things, and this is important to know, because some of the laxatives that we give are stimulants. And basically, they tell your intestine to move.
And
Right?
is an ileus also an obstruction?
Yeah, that's kind of the, yeah, exactly.
What about like if?
Now, an ileus can also mean that it's just sort of paralyzed. So like after surgery, like if you have bowel surgery where you're messing around with your intestines, your large intestine, your bowel kind of like freaks out and stops moving. And so an ileus is kind of when it's not moving. But that happens, and that's something to know if you have med-surg patients that have had bowel surgery. You want to make sure you start to hear those bowel sounds, because that means that things are starting to move, right? But that brings up a good point there. Movement. Right? I should put it over here. Movement. So think about diarrhea. All right. You sit there, you listen to your stomach heart, right? And then you know, oh goody, here it comes, right? You've got that movement. It's noisy. That is motility, right? So that's one of the words you guys are going to hear, motility, right? That's one of the things we want to see. So think about when you have patients that are in bed, or in a hospital bed, they're laying around. You want to make sure their bowels are moving, right? That's the process here to get rid of that stuff, is you want your bowels moving. Think about your parasympathetic, rest and digest. That is stimulating things to move, right? So motility is really important. And it's one of the things we fuck with, motility, right?
So what if they have been on laxatives for a long time while they were in the hospital? Will it go back to normal?
It depends on what you're using, number one. Number two, hospital setting, you probably won't, depends on the patient, you're gonna have them on a stool softener or something first, right?
Yeah,
Why do we have a lot of constipation in the hospital?
because they're not moving around.
Pain medication.
Not moving,
Pain
pain medications, they're dehydrated, lots of things that cause that. So what we do, we wouldn't necessarily give a laxative, we would give a stool softener or something like that. Or we would try to give them more fluids to hydrate them, right? Fiber, we've got psyllium and we have things like that. We will step it up. So if you have a patient that has not pooed in like a week, you probably want to do something about it, unless that's their normal, which that's a little bit long for normal. But some people don't go to the bathroom every day. And so you have to ask them, is it normal for you not to go to the bathroom for 3 days? Because they might be like, oh yeah, that happens all the time. If that's the case, you may not be worried about it. But if it's somebody that's like, oh, I'm on the dot every day, and they haven't had a bowel movement in 5 days, we're gonna gradually, and you've been giving stool softeners and you've been giving things like that, you're gonna step it up, right? Then you'll go to the laxative.
Prune juice.
Huh?
Warm that prune juice.
To drink or to put it as
To
an
drink.
enema?
To drink.
Yeah.
Milk and molasses, that works. So, it depends. You don't want people to be on certain laxatives for very long because they're stimulants. And you're stimulating motility, right, with some of those laxatives. You're stimulating the movement. But there's lots of ways that we can help with movement. Bulk forming, right? We talked about the bulk forming, fiber, metamucil, things like that. What that does is it bulks up the fecal matter. And when you bulk it up, it distends the intestine. When you distend it, it triggers it to move. And so a lot of the laxatives, one of the things they do is bulk things up. They pull in water from other places, right? Because if you think of somebody that's constipated, it's dry as a bone, for whatever reason, right? Hydration is a big piece of it. And then some of these other laxatives we use will pull water into the intestine to soften it up. So that's one of the ways it works. So, let's see, obstructions, movement, motility. Okay. So, this is kind of our big picture, right? We're talking about all these different things. Okay. So, let's look at nausea, vomiting. Ooh, good golly. Diarrhea, vomiting, acid control. Right? Those are kind of the big categories that we're going to deal with in the GI. Okay? Right? So nausea, vomiting, those are your antiemetics. What's one of the more commonly used antiemetics?
Hysteria.
Zofran, yep. So antiemetics. So Zofran is a common one. Okay. Diarrhea, what are we trying to do with diarrhea?
Clumped up.
We're trying to slow it down, right? Think of diarrhea. Think of what's happening. It's because you have this excessive motility happening, for one thing. Why do we have diarrhea? Why do we have vomiting? Why do we have nausea and vomiting? It's a defense mechanism, right? Think of toxins. Think of, you ingest something that's nasty, your stomach knows it, and it's gonna react, right? You're gonna vomit it up, or you're gonna try to get it out of your body. So really, these are defense mechanisms for lots of different things, right? Now, sometimes we induce it ourselves. We eat something that, or we overeat something. Nausea and vomiting can happen from just smells, sights, right? There's a trigger zone in your brain that triggers nausea and vomiting. And so that can be triggered by sights, smells. A lot of times if you, I was on a trip once, and I feel really bad, but.
Dehydration?
Yes.
I got you, girl.
Dehydration, yeah, malnutrition, weight loss. Now that would be chronic, right? Now if you have vomiting for a few days, you're still good, you might lose a little bit of weight. Most of it's water, but chronic. There are people that have chronic diarrhea or they have chronic or psychological issues, right? Think of bulimia, things like that. So yeah, malnutrition, because if your motility, your GI tract is so fast, it doesn't, nothing moving through there has time to be absorbed, it goes right on out. So yeah, all these things are things that you could see, right? With diarrhea, we talked about metabolic acidosis, and we talked about metabolic alkalosis, right? Which one is the excessive diarrhea cause?
Excessive.
Huh? Do I hear both?
Alkalosis.
You sure?
I don't know.
Yeah.
So it's going to be metabolic acidosis. Because remember, In diarrhea, what you're getting rid of is bicarbonate. So you're getting rid of the base. So you're going to shift to the more acidic situation, right? Because you're getting rid of all that bicarbonate. Yes. Exactly. So think of it like that. When you're vomiting, you're getting rid of all of the acid in your stomach. And so it's going to shift you to an alkalotic situation because you've gotten rid of all the acid. So think of it like that. But that's something you guys would be thinking about if you have a patient that's chronically, or chronically, that's kind of a bad word, that means it's all the time. But it's definitely a situation where you would have one or the other. So keep that in mind too. Your acid-base balance can get jacked up, right? And it's easiest to think about vomiting, because vomiting, you're getting rid of the acid. And so you know you're going to be more alkalotic, right? So then, you know, diarrhea is going to be the opposite. So, diarrhea, we try to stop it, we slow it down, right? So we have medications that are going to slow motility. Opioids are great at that. There are anti-diarrheal medications that have opioids in it. And they work great because they stop you up, right? They slow things down. Okay, let's see, vomiting. Again, you know, when you're talking about vomiting, antiemetics, if you can control that nausea, usually nausea is before the vomiting, right? So if you're controlling that nausea, you're controlling that part of the brain that's essentially telling your body to vomit. We'll talk more about that probably next week. Acid controlling, okay? So these are biggies because we do this a lot, right? There's a couple of ways of doing this. We talked about two of the ways, right? What were they? Think of our quiz.
You mean magnesium? Calcium one?
So, what about it? You're on the right track. Yeah. So like calcium carbonate,
Yeah, calcium carbonate.
Tums, exactly. Or the aluminum containing, magnesium containing products. Those are called acid neutralizing, okay? So you have neutralizing medications, okay? Those are your Tums, sodium bicarb, those are neutralizing.
What about the protein pump-based nutrients?
That's your the other type, exactly. So your neutralizing ones, do they decrease the actual acid production? No. All those do is neutralize the acid sitting in your stomach, right? Your PPIs and your H2 antagonists, those actually reduce acid. Okay, so they work a little differently, but those will actually reduce the acid production. These do not. So think of, you have a beaker that has acid in it, and you just pour calcium carbonate in there, it just neutralizes what's there. So these, so that would be like Tums, is a good example. Those, they work fast, so that's why a lot of people, if they start to feel that upset stomach, they'll go take some Tums or they'll go take something like that, and it helps because it neutralizes that acid in your stomach. What happens when you neutralize the acid in your stomach?
It's not gonna break down stuff as easy.
Right. So do you think there's an issue with taking neutralizing drugs with other medications?
Yes.
Absolutely. That's one of the biggest contraindications to taking Tums, for example. Because if you take it at the same time you take your heart medication, chances are your heart medication is not going to work. Because you neutralized all the acid that's going to be needed to break down medications, right? So that is one of the biggies that you guys will need to remember. There's a 30-minute to an hour time frame before you should take any medication with one of these. And typically, if you have a heart medication, you want to educate your patient to take that first, right? Deal with the heartburn for a bit, and then after 30 minutes to an hour, then take it, right? Because the heart medication is more important. That's for comfort. right? So, in our quiz, there was that one question on there about the patient in the clinic that is self-medicating and has been self-medicating for a long time with an antacid. Think about drugs like ibuprofen, NSAIDs. What do those do?
GI bleed.
Those predispose your patient to GI bleed because NSAIDs decrease that protective layer in the stomach. Okay? So if you have a patient that has rheumatoid arthritis or has something that they need an anti-inflammatory for, and they're taking a type of NSAID long term, they don't realize or they don't know that also, this should be an education piece from when they come out into the world, they don't know that that's decreasing that protective layer of their stomach. They start to get heartburn. And so the first thing they're going to do is go, oh, I have heartburn. I've never had heartburn before. I'm just going to start taking some Tums, right? So that could be masking the underlying issue, which is a gastric ulcer, because those NSAIDs are reducing that protective layer because they're taking it long term, right? So you want to say, hey, we need to talk about that. We might need to put you on a PPI or an H2 antagonist because we need to reduce the actual acid in your stomach because you're taking an NSAID long term. So you want to tackle the acid production piece rather than just covering up the acid, right? So that was one of those quiz questions that we had today. Think about that. Because people are going to self-medicate, right? They know they feel bad, so they're going to do stuff. And these are easy because you can go to the store. They're a good source of calcium for some people, make you feel better. But be careful because, like we talked a little bit, if you have aluminum containing, and a lot of these neutralizing medications, like the Tums and things like that, calcium citrate, they have aluminum, they have calcium, they have sodium, magnesium, right? You have combo drugs that have aluminum and magnesium in them because aluminum is constipating and magnesium causes diarrhea. So they'll put those two together and hope that somewhere in the middle the patient's kind of balanced. But the whole when to take medication timepiece, that's a biggie with those. So the other main class of drugs, PPIs, your H2 antagonists, they reduce actual acid, okay? So we'll use those a lot with patients, okay? So some of the other ones that, I have a video, we probably won't watch it this week, we'll watch it next week. But you have sucralfate, you have Pepto-Bismol, right? How many of you guys have had Pepto-Bismol? Makes you feel better, right? So that one coats your stomach, neutralizes, coats. Sucralfate, actually, if you have ulcers, it will protect the ulcer from getting worse, so it'll keep the ulcer from getting worse. But again, those coat the stomach, right? You want to take those with other medications? No, you don't, because the same thing is happening. That absorption, that breakdown piece is not going to happen because you have something blocking that from happening. Pepto-Bismol. What is one of the ingredients in Pepto-Bismol that you have to be careful of? Right. Exactly. Bismuth, salicylate, think of aspirin, similar to aspirin. So you don't want to give regular, they have kids Pepto-Bismol, but be careful giving regular Pepto-Bismol to kids because it has a salicylate in it, which is similar to aspirin. So you could see rice and syndrome in that as well. I don't think it has it. But if you have somebody that's on an antiplatelet, right? That salicylate is part of an antiplatelet. So be careful. Any questions on those? So we talked about the ICU, and we talked about giving a PPI in the ICU. Right? Think about when your sympathetic nervous system is kicked off. Right? We talked about that. Stress. That impacts the digestive system as well. Right? So you get this increase in acid. Now, if you're in the ICU, or even if you're just stressed out all the time, you might experience more heartburn, right? And a lot of people will take one of these over the counter at Prilosec. The PPIs, they all end in Pralicillin, omeprazole, things like that. Your H2 antagonists, they end in Tidine, like cimetidine, famotidine.
Does that work?
This one here is antagonist.
So I just want to tell you something weird.
Uh-oh.
My kid,
In that case, it's also working with peripheral histamine receptors. So that's kind of interesting that that's the case. It's interesting there's a little bit of water too.
yeah, and he's only 6, so that's
That's a
great.
bummer.
We were at Pecos this weekend, and he busted out in hives like this big
Yeah.
on his whole body, and
So-
I was like,
We'll stop there for today. We'll pick this up next week. Any questions on that? I mean, so